All right. Well, I am Charles Goldfarb, and I am joined today by Dr. Martin Boyer. We are two hand surgeons at Washington University, and we are going to talk about lumps, bumps, and dupes. Welcome, Dr. Boyer.
Hey there, Chuck. Glad to be here. Thanks for hosting.
Thank you. In case the viewers can't tell, Dr. Boyer is my senior partner, meaning he's been
Much
around a little.
older, much weightier, and I even have less hair than Dr. Goldfarb.
But much more wisdom. So
maybe yes, maybe no.
we are going to talk about how we think about lumps, bumps, and by dupes, we mean Dupuytren's contracture. And so these are common things that many of the viewers may currently have or know someone who has, and we'll talk about how we think about these things, how we diagnose them, and how we offer treatment. Is that a fair summary, Dr. Boyer?
Sure is, Chuck.
Outstanding. All right, let me present you with a hypothetical situation. We'll start really common. So let's say you have a 15-year-old young lady who comes in with a bump on the top of her wrist. She says that it's been there for about 6 months. It gets bigger and smaller with activities, and sometimes it hurts when she does push-ups or plays sports. Other times it doesn't hurt at all. What are you thinking?
You know, the story that you're giving me, Chuck, is that of a fairly typical, what's called a dorsal carpal ganglion. Dorsal means it's on the back of the wrist, or this side of the hand, this side of the wrist, the nail side. Carpal means wrist, and all the word ganglion means is a fluid-filled cyst. So it's a fluid-filled cyst that comes from in between two of the small bones that make up the wrist and causes swelling, sometimes pain, very rarely limitation of motion, but often a limitation in activity because of secondary pain. And sometimes the patients perceive that the wrist is clunky or unstable. It's not only in 15-year-olds, but it's also in 30-year-olds, 45-year-olds, and I've seen them in people after the age of 50 as well, although it is a little less common.
Fair enough. When people ask what causes these ganglion cysts, what do you tell them?
The vast majority of the time, we don't know what causes them. Generally speaking, if I'm trying to establish some sort of etiology or some sort of causation for this, I'll tell the patient that it's because of a very small tear in the ligament in between the two bones in the wrist that sometimes allows fluid out, but doesn't allow the fluid to flow back into between the bones. So it's like a one-way valve. In other words, the fluid gets produced in the wrist, then escapes into the ganglion, but can't get back. And that's why you sometimes have changes in size of this. But usually there's no real cause and there's no real trauma at all.
Totally.
What do you tell them anything differently?
No, totally agree. And I would say, for the purposes of this discussion, I would lump two other ganglions into this group. One would be one on the palm side, which we call a volar or palmar carpal ganglion, which almost always is right where my finger is. And sometimes we see them right where the fingers meet the hand. Those are very similar in nature, also related to unknown causes, but they're a fluid-filled sac, right?
Right. The ganglion that you're talking about often presents a little differently. The patient usually has a mass. We remember the story from when we were kids of the princess and the pea, where there was a small pea underneath 20 different mattresses, and yet the person who was sleeping could still feel that pea. The mass in the finger is very much the same way. It's very small, but because it's in the wrong spot, it's very irritating. And patients will often complain of local discomfort and disability as a result of that.
Yeah, totally agree. And you're referring specifically to the ganglion cyst, which we see right here.
Exactly.
And my patients often complain of discomfort when grabbing the steering wheel or working out with weights, things like that.
Yes, I agree.
So I'll give you my brief treatment algorithm, and I'd love to know, and we may not completely agree on this, but for a wrist ganglion, whether it's top or bottom of the wrist, I offer a wrist brace, although I don't have great confidence that that improves things, but it's no problem to try it.
No argument.
Okay. The second step up the ladder would be either an aspiration, where we put a small needle in and suck the fluid out, and sometimes we inject a little steroid. I'm very comfortable doing that. I think it's a reasonable thing to do, but the success rate is only mediocre. How do you think about it?
I think the success rate is even less than that. I'll take a little bit of a different tack. Rather than try and suck the fluid out, if the ganglion is not big, and I mean big, like at least the size of a large marble. I've had very bad luck trying to suck the fluid out. And what I'll try and do is inject local into that ganglion and pop it in the same way that we would pop a zip, under the skin, of course. And and then
I've got the visual. I've got the visual. Thank you.
Thank you. If you come really close to no,
Oh, God.
but if you do that, then sometimes it won't come back. It's low tech, it's low cost, it's low intensity, low pain, and in my book, that's a win. So even if it's less than a 50-50 chance, it's certainly worth that chance to try and get the patient better without having to resort to something more invasive.
And when do you think about surgery for a ganglion on the top of the wrist or the bottom of the wrist?
I won't say never, but it's never my first choice. Like you, I'll tell the patient about the natural history of this condition, that it will come and go, often unrelated to activity. And if the patient's satisfied with that, then I'm happy to let the patient live with it. That said, if the person has pain, if they have local pressure, and sometimes on the volar ganglion, the one that's on the front of the wrist, the palm side, there can be pressure on a very small nerve that goes by, that innervates this area of the thumb pulp, the thenars. I'll sometimes counsel the patient that the best way to treat that is by excision.
Yeah, I agree. Surgery is never the first choice, but having said that, surgery is a reasonable choice when the patient decides. It's totally a patient-driven decision. And the numbers I quote are 95% cure rate for a ganglion removal on top, meaning it never comes back, and about 80 to 85% cure rate for ganglions on the palm side. And then what we do surgically, and I think you and I agree on this, you may or may not agree on those numbers, but we generally put you in a little half cast for 2 weeks. After surgery, you can move your fingers, but not your wrist, and then we ramp up activities thereafter. Same.
I think the numbers, at least in my experience, being older and balder than you, are a little better, but I think that it's a low risk. There's no risk surgery. It's a low risk surgery in terms of infection, loss of motion, nerve injury, or anything like that. But the patient usually has a fairly satisfactory result, and they're happy that their cyst is gone. Actually, my wife had one of these 15 years ago, and all she has left is a scar. No pain, no trouble.
Perfect.
Happy wife, happy life.
All right, let's transition to another bump that's common in both of our practices, maybe a little more common in your practice. I tend to treat patients that are a little younger, but we can see bumps or lumps on the top of the finger.
Change the finger. Change the finger, Chuck.
Top of the finger, right here at the last knuckle. So right there, we can see what looks like a lump. Sometimes it's just a hard bump or swelling, which seems like it's from the joint. And sometimes there's a soft component as well. What do you think about with those patients?
Those patients are suffering from bone spurs of that joint, usually as a result of arthritis. Now, you and I both know there's many different kinds of arthritis. This is a arthritis where it's called osteoarthritis. And what that is it's not really an inflammatory condition, but more of a degenerative condition from constant wear and use of that joint. They're bone spurs. I can't remember whether they're called Bouchard or Heberden. I think they're Heberden's nodes, if we wanted to use a
fancy name. Fancy name.
Yeah, I can't remember what the
eponym
word is. The eponym. Thank you. That's what happens.
You're older. These things happen.
And the words begin to leave. But these are interesting. Patients will often complain that they don't like the way they look. And I really don't know what to say, except it's not cancer, it's not heart disease, it's just your hand. But often patients aren't satisfied with that. Do you have any tips on how to talk people off of the ledge, as it were, from getting an operation for this that really is not going to make them any better? It's just going to make them different.
Yeah, I think sometimes, well, I agree with you. And I love the line, it's not heart disease, it's not cancer, because for you and I, that's a lot of what we do. You know, we don't see a lot. Now, sometimes bumps can be concerning, but we don't see a lot that requires surgery, but surgery can be helpful for pain, occasionally for appearance. I don't know. I think for some patients, the complaint is pain and surgery can help with that. For some patients, the complaint is appearance, and I really discourage intervention for it. I don't think needles have a big role in this. I don't think braces have a big role in this. Usually it's reassurance and, you know, and occasionally though it is surgery, and surgery can be successful, but it doesn't cure the underlying problem, which is arthritis.
No, and that's correct. The one thing that I will just differ with you perhaps a little bit on is I think cortisone injections in painful DIP joints, which are the joints out here near the tips of the fingers, actually are incredibly useful in the right patient. Often the patient complains more of pain than of limitation of motion or deformity. And I use the deformity word as a medical term, not as a, you know, a mean-spirited pejorative term. Patients that have pain will often benefit substantially from a very tiny little cortisone injection into that joint. At least that's been my experience.
I think that's fair. There's a little hesitation, I would say even on my part, to avoid repetitive injections in that area. There's not a lot separating the skin from the joint, and there are reports of infection. I think one injection by an experienced provider like yourself makes sense. Repetitive injections probably don't. And then again, occasionally surgery makes sense, but for most patients, we try to avoid it. Sorry.
I agree. I think that makes complete sense.
All right, let's talk, before we switch to dupes, and we already have a question about Dupuytren's, but before we switch, I was going to just discuss other lumps and bumps as a group and just ask how you think about them. So say someone comes in with a lump or bump somewhere else in a finger, not in a classic location. I'll go first and just say that for me, I think about the age of the patient because that helps me understand things. I think about pain and duration and function. How do you think about it? I'm sure you have a well thought out thought process.
You know, first and foremost, I think it's important for everybody who's listening to realize that if they have a bump or a lump anywhere in their hand, it's not cancer. Okay. The chances of it being something sinister, something bad is so low as to be almost zero. In fact, in 23 years of practice, it's not zero, but in 23 years of practice, I've diagnosed one cancer of the hand, and that was in a patient that had a kidney cancer that went to the hand. So I think it's extraordinarily unlikely. So I just want to put everybody's mind who's listening at ease, that's thinking that, oh my God, I have a bump in my hand, I have cancer. You don't have cancer. What I look for is I look for the location, first of all, where Dr. Goldfarb said it was on the front of the hand. It's usually something called a pigmented villonodular synovitis, which is a giant cell tumor meaning not cancer, but tumor meaning growth. That's the vast majority of the other lumps or bumps. There's other minor things such as skin things, or tendon things that can cause bumps, but they're fundamentally rare. And again, cancer is even rarer than those.
Yeah, I think that's great. I'll add a little bit to what you said. So first of all, you know, Dr. Boyer and myself, and we have 4 wonderful partners. We're here because if you have a lump or bump and it concerns you, or if it hurts you, we're happy to see it. That's what we do. And we can reassure you, usually without advanced imaging, meaning we don't usually order MRIs or other tests. Occasionally we do, but that's pretty rare. Second of all, I agree with Dr. Boyer. It is super rare that we diagnose a bad cancer. Super rare. Occasionally, because of who we are, we're at Washington University, we're at Barnes Hospital, we are sent in patients from all over the Midwest that may have something more going on, and that happens. But it's uncommon. And so I agree that these, in general, rest easy because these are not dangerous or concerning lumps or bumps. But that's what we're here for. If you're concerned, come see us, and we're happy to take a look at it.
Correct.
Okay.
Dups.
Yeah, let's go to Dupes. All right. So Dupuytren's
Love it.
disease. Yes. So you want to give a brief explanation of Dupuytren?
Sure. It's a hereditary condition that causes tissue that lies between the skin of your palm and the tendons and the bones of the palm to actually draw your finger down either in that way or in that way. It's not uncommon. It's not common, but it happens mostly in Caucasian patients, although I have seen it in several African-American patients with some Norwegian or North European, Scandinavian heritage at some point in time. There were thoughts in the past about it being related to liver disease. I don't know that anybody thinks that anymore, but generally speaking, it's a non-painful condition that causes difficulty with the patient straightening their fingers out. Never does the patient have any difficulty making a fist. It's usually the golfers that complain that they can't get the hand in the golf club or can't reach into their pocket to get the golf ball, not that they can't reach around their club to hold the club. But it's a condition that a lot of treatment has matured over the last, I think, probably 15 or 20 years. And I know I was a bit of a naysayer on one of these methods, but you convinced me to go visit the guy who brought this over from Paris, from France, Charlie Eaton, who was in Jupiter, Florida, who's since retired. And I do a substantial number of needle procedures, is what they're called, in the office every week to treat patients with this.
All right. So
as do you.
Yes, absolutely. So let's rehash. So first of all, as Dr. Boyer said, it's not a disease of the skin, although sometimes the skin's involved. It's not a disease of the tendons. It's the layer between. It can start off as just lumps or bumps. And so we had a question that reads, in the last week, I had a head of a tack-sized lump show up in the palm between the two lines and below my ring finger. That is absolutely a Dupuytren's nodule until proven otherwise. And it can start off as just a lump, again, typically non-painful, occasionally uncomfortable, and then it can progress, as Dr. Boyer said, and draw the fingers down, typically ring and small, but it can be anywhere. Runs in families for sure. My dad has it. I'm sure I'm going to get it. We're from Northern Germany. Yeah. How about that?
Das ist nicht so gut.
I'm going to keep it in English just for everyone's benefit, including my own. So as Dr. Boyer was implying, I think of this as there are three treatments for this, if treatment is needed. And again, treatment is dictated by the patient. Agreed?
Right. 100%. I would have said 4, and the first way is no treatment at all. So
yep.
Please continue. Sorry.
No. That's perfect. So the classic treatment, and I think it's still what we would call the gold standard, is a big surgery where we make zigzag incisions in the palm, in the finger. We find the nerves, arteries, tendons, keep them safe, and take as much of the junk out, the Dupuytren's out, as we can. But a couple of important things, and I want Dr. Boyer to weigh in too. Number one, it doesn't cure you. It can still come back, although typically if it does come back, it's a longer time away. 2, the recovery is not super fun. And Dr. Boyer and I still do this surgery, but we try to avoid it. The recovery requires therapy, requires wound healing, requires really taking the time to get this right, and it modifies your activities for 3, 4, 6 weeks. What else would you want to say on the open procedure?
No, I think, your point is so well taken about the surgery being a tough operation, not only on the surgeon on occasion, but on the patient in terms of recovery. As Chuck said, the patient starts off with an inability to straighten out the finger, but a full ability to make a fist. And what they end up with, at least for the first 4 to 6 weeks, is an ability to make the finger straight, but a very, very tough time making a fist because you're swollen, you're painful, and it's not an easy go of it for some people.
Yeah, so Dr. Boyer and I and all our partners agree that we start therapy soon after surgery to try to maximize your ability to regain your motion when we have to do this operation. And again, it's in some patients, I did one yesterday. In some patients, it's necessary, and it can be a great operation. If we can avoid it, we avoid it.
100%. And I try and avoid it because of the reasons stated.
Second intervention is something called collagenase. And you may have seen this on TV. I haven't seen it, but apparently John Elway's on a commercial talking about collagenase.
Yep.
And collagenase is a chemical which is injected into the Dupuytrens that dissolves it. It's pretty safe. It's pretty effective. It's pretty expensive. And we've chosen not to offer that treatment because we think the third option is better. But before I get to the third option, any comments on the second option, the collagenase?
You know, I think that, Chuck, I think surgeons that do it really, really like it. And it's really effective in some patients, and in some patients, it's not. You and I think, have chosen to not do it for a couple of reasons, not because we have any philosophical problem or any problem with the product, but because it requires an injection and then a return to the office the next day, at least the way I was taught to do it. And in some cases, until you've done it a lot, there's a risk of irritation to the skin. I do know that surgeons that do it love it, patients love it, but for those reasons, you and I have chosen to not make it part of our practice. There's nothing wrong with it. It just that we don't do it.
Yeah, that's well said. It's expensive, but Medicare covers it. Most of the insurance companies cover it. So it's not really necessarily more out of pocket for you, the patient. But Dr. Boyer and I try to think about cost globally. And the third option is what we call the needle procedure, or some call the needle aponeurotomy, which we both really like. And to briefly rehash what Dr. Boyer said, I went at a meeting, I met Charlie Eaton, he shared his experience with this procedure, and it's just really a great story. At the request of a patient, although she didn't pay, he flew to Paris, learned this procedure from rheumatologists, so non-surgeons, came back to the States, and immediately was swamped with patients, and for very good reason. And he shared his experience. Dr. Boyer and I started doing this in St. Louis back in 2008. We decided that it made sense to fly to Jupiter, Florida, make sure we, did it how Dr. Eaton did it and learn from him. And then for the last 12 years, we've been doing a lot of this in St. Louis with great results. One more thing, and then I'll stop.
It's fine.
There was
that pause, so I thought it was my signal.
Thought you're going to jump in? No, I can't let you do it. Recently, the literature. So, we depend on people like ourselves who are in academic medicine sharing their results to the world. The literature has been filled with papers looking at the different techniques, and it has become clear that the needle procedure is really good as, if not better than, the collagenase, and in a lot of ways as good as, if not better than, the open procedure. So that's reassuring. It is a disease we can't cure, so you may end up coming back, but it's a great procedure, and I'll stop there for a second.
Yeah, I mean, I really have nothing to add. I think that the procedure, historically, it's actually very interesting. In France, where they have a national healthcare system, and also in Canada, this is actually a very commonly done thing because patients with Dupuytren's contracture just can't get in to see a hand surgeon and can't get in to see someone who will do an operation on them. And so instead of having a big operation to release their contracture, the patient goes to the rheumatologist, who's a joint doctor in France, and has a small needle procedure where the cord is cut using a small needle. And the patient is able to straighten their finger out, not perfectly, but certainly better than the way it was when they came in. And then they get up and they walk out of the doctor's office and they resume normal activity, sometime within a day or two, sometimes within a week, sometimes that day. So it's really changed completely. And I was a non-believer, I got to tell you, but it changed completely the way I treat patients with Dupuytren's contracture now. I can't remember the last time I did a big operation for it. As you said.
Yeah. So two things. One, let me ask and answer a question real quick because we're almost out of time. And I would say that the question is there a connection between Dupuytren's and inflammatory arthritis? And my answer would be no. There could be an association. One might have inflammatory arthritis and have Dupuytren's, but I don't think they're related. And second of all, as Dr. Boyer just said, neither of us really believed in this, and then it's changed our practices and therefore changed the lives of many of our patients. So the old adage that you can't teach an old dog new tricks is clearly not true here. All right. In our last couple, we didn't talk about bald dogs. In our last couple of minutes, briefly talk a patient through the process. So they come in, let's say they have an isolated cord of the ring finger, and you can see a band running here, and it's mainly affecting where the finger meets the hand. And they come in and you talk to them, they said they want the needle and you're going to do it that day. Briefly talk to them about what to expect.
Basically, the patient is seated in the office. There's no gowning. There's no draping like in an operating room. And what I do is I basically prep, meaning with an iodine stick, I clean the area up. I take literally the smallest needle that is manufactured, a 30 gauge needle, and put in the tiniest amount of local anesthetic right where I'm going to put the bigger needle. And then I go, and then I pop the cord. I will tell the patient that if they're queasy with the sight of blood, probably a good idea to not look down. What I usually say in jest somewhat, but in truth somewhat, is it always ends up looking like there was a murder, even though it doesn't. But that way the patient doesn't have any surprises if they do have some bleeding from the skin edge. But usually that's all there is. At the end of the procedure, there's a couple of holes in the palm. Have the patient make a fist. Then Sarah, my nurse, or Nermina, your nurse, would wrap the patient up and send them off to therapy to get a splint, which they would wear at night for 4 to 6 weeks. Even though I don't think Charlie used splints, I feel better if the patient wears a splint for 4 to 6 weeks at night at least.
Yeah, perfect. And so we obviously think about things the same way, at least this. I will say I'll add a couple of things. Number one,
as we get older, we're regressing to the mean, Chuck.
This is true. The injection that we give is a little bit of xylocaine or lidocaine, like when you're going to the dentist. It stings for about 1 second. And then after that, you don't have any pain. Now, it may take a couple of spots to work through a tougher cord, as we call it, but it stings a little bit for a second, and literally that's all the pain you have. That's pretty amazing.
And just before anybody says, well, they don't know, how do they know it's only a second? I have had injections in my hand. Trust me, it is only a second where it hurts.
Yeah, it is not bad. And then I don't know what he's talking about, blood loss and this. And my patients never lose any blood at all.
Never. Never.
Just kidding. I'm just kidding.
Never.
But in all seriousness, as we close, I would say Dr. Boyer and I, our practices look slightly different. But of all the procedures I do, and I do some cool things, big things, as Dr. Boyer does, there's almost nothing that has a higher patient satisfaction than this needle procedure for Dupuytren's. Do you agree with that?
I really do. Patients come in with something that they think is a real big deal, and 5 minutes later, you change their anatomy so substantially, and they're surprised that it was so quote unquote easy, is really amazing. And it's incredibly gratifying. And the patients say to me, when can I play golf again? And my answer again is, well, what time is it now? And invariably they don't play golf that day, but they'll go back pretty quickly.
Soon after. All right. So we're going to wrap it up. I want to say, first of all, thank you for watching. We greatly appreciate your being here, and hopefully you've learned something. Hopefully you've had a little fun at Dr. Boyer and our expense. We like what we do, and we like each other. Lumps and bumps and Dupuytren's are something that we treat regularly. We'd be happy to see you. We have 4 great partners. There are 6 orthopedic hand surgeons at Washington University and Barnes Hospital. We are more than happy to see you and take care of you. So let us know if we can help. Dr. Boyer, any closing comments?
Yeah, we're just in all the different locations. We're down at the Center for Advanced Medicine. We're at South County. We're at Progress West. We're at West County, the Orthopedic Center in Chesterfield. You come to us, we've come to you.
And we'll even do house calls via Zoom. So that's how good we are. If you want to have a consult, no, we can't do the needle procedure, but we can make a diagnosis often via Zoom call if you like that.
Correct. My kitchen table's off limits for this.
True. All right, everyone. Have a great day. Thanks for joining us.
Good afternoon, everybody.